So again, thank you everyone for joining us. Some tips and reminders as we all listen to the webinar. One is that kindly ensure that your microphones are on mute if you're not speaking. So you can place your microphones on mute by right-clicking on the microphone icon next to your name, and this will place the microphone on mute. And then second is if you're having some trouble seeing or hearing the presentations, please try logging in and out of the call first. And if that doesn't work, to restart your computer. That resolves about 90% of some of the problems you might be having. And then also, if you continue to have some problems, you might want to ask any IT support, or you can send me a message if you need to, and we'll help you as much as we can. Also, for better audio quality, we recommend using headphones. And as we listen to the presentations, if you haven't done so already, if you can let us know where you're calling in from, which organization you work with, and if you're in a group of people, how many people are with you. This helps us to try to gauge our audience and where you're calling in from and which organizations have participated in the webinar. So without further ado, I'll turn it over to Kate Harrison of the Children's Investment Fund Foundation to moderate the webinar.
Thank you, Jessica, and a warm welcome to everybody that's joined the webinar. I'm delighted to welcome you from CIF in London. My name's Kate Harrison, and I'm the HIV manager at CIF. And I'm very happy to be able to launch this webinar. We've got some fantastic speakers coming to join us to speak about the new report that we have, which presents the promising practices from the Accelerating Children's Treatment Initiative work. And it's a really fantastic report giving concrete examples from country practice and really showing all the different ways in which systems were strengthened in favour of supporting children's HIV treatment. Now we have a lot of speakers, so I'm not going to go through and list all those speakers. I will introduce each speaker as they come on. And I'd like to draw your attention to the fact that there will be time for questions halfway through and then another round of questions at the end. So if you have questions, do put them in the comment box. So I'd like to move straight to welcoming Ambassador Deborah Birx. She's the US government Global Aid Coordinator and Special Representative for Global Health Diplomacy, and heads up the President's Emergency Program for AIDS Relief. Together with CIF, PEPFAR and CIF were partners in the ACT initiative. Welcome, Dr. Birx.
Great, thank you. And I'm just going to kick off briefly, but really want to thank everyone who's on the phone, because it was really UNAIDS, WHO, UNICEF, and Elizabeth Glazer that really stood up and raised the alarm bells, I think, in 2013 and 2014 about how far and how dramatically children were lagging behind in treatment. And we immediately had discussions with CIF about this issue. And I think from PEPFAR's perspective, the President's Emergency Plan for AIDS Relief, to have CIF agree to partner with the U.S. government was quite groundbreaking for us, because it said to all of us that they were going to work together with us and work together to ensure that we had reliable data on testing and treating children. And I think that was really a hallmark of the work that we did together, was ensuring that we had results and impact. And so we just go to the second slide. I think you'll see that what was originally, or do we do that? We're just getting technically organized. I think the second slide, well, is an overview of the partnership. So if you go to the third slide, it talks about partnering to save children and really accelerating children's treatment. And It began as a $200 million partnership, and I think what was exciting about us is we had together had a very ambitious goal and chose countries that had lagged the furthest behind, and I think you can see those countries: Cameroon, DRC, Kenya, Lesotho, Malawi, Mozambique, Tanzania, Zambia, Zimbabwe, noting that obviously numbers changed in the midst of the program with a very different number of children with HIV/AIDS due to the incredible success of the prevention of mother-to-child transmission programs. Next slide. And I think these were the 7 pillars that we all focused on together. And I want to end a little introduction by going to the next slide and leave it to George to present the rest. But the exciting thing from my perspective was all of PEPFAR engaged in this. And what do I mean by that? It means that our orphans and vulnerable children's programs around the globe in all of our PEPFAR countries went looking for the children that were missing school, the children who were malnourished, the children who were sick, and tested many of them. And large number of our targets came from those individuals. But importantly, they also moved to family testing to really identify the children of HIV-positive mothers who came through under B+. And so not only did these 9 countries dramatically increase the number of children that were receiving treatment, but all of the PEPFAR countries moved dramatically up. And I think that was the exciting piece from my perspective, is PEPFAR as a whole was more successful because of this initiative. And the whole PEPFAR family locked on to this issue of undertreatment of children. And across the board now, our pediatric programs are now within single digits of our adult programs, getting into the 50 to 75% range for pediatric treatment. That's not to say there isn't a lot more work to do in identifying early pediatric cases and getting children on treatment, which we would love to see within the first week of life. If we're talking about same day, same site start for adults, we would like the same thing to happen for children. But I think the other piece of it is, because of its success, we moved, now those of you who follow the bureaucratic COP process, that's our country operational plans, will notice that we moved this commitment of our $150 million into the actual country operational plans to make sure that we maintain and expand pediatric treatment into the future. So yes, it had a short-term impact, but it is having a long-term impact in how we work and how we work together. And I just want to close again by really thanking SIF, who took a chance on us to work together in a new way, and to GAPf, who really set the scene to know that we needed to do better. And I think together we all did better. So I'll stop there.
Thank you so much, Ambassador Birks. It's fantastic to hear you set the scene and to speak about some of the earlier history that happened actually before I joined SIF, and to hear that great commitment that was made by both organisations. And I think it strengthened us both. So now we'll move to the presentation with more detail about examples from the implementation of ACT, coming from Dr. George Sibry. He's the Director of HIV Treatment Care and TB, and he's a Senior Pediatric Technical Advisor at PEPFAR. So George and the PEPFAR team have spent many a long hour on conference calls together with me and the SIF team to continue to track all the data and all the fantastic promising practices that have been growing out of the ACT work over the last 2 years. So George, I'll hand over to you now. Thank you.
Great. Thank you very much, Kate. And I think this webinar is not just a chance to celebrate the great results that we've seen and things that we've learned, but also the nice time we've had working together on this partnership. So thanks very much for giving me this opportunity. Ambassador Birks has already set the scene for us in a really exciting way, and I think that makes it easier for me to then go over in some detail what exactly we had as results and the kinds of promising practices that we observed. So here you see the 9 countries, and you can see divided by the under 15 group and the adolescent 15 to 19 group, what these countries managed to achieve in terms of getting children and adolescents on therapy by the end of the 2-year ACT initiative at the end of our financial year 2016. And altogether, it was almost 562,000 who ended up in the ACT countries on treatment. And as Ambassador Burke said, PEPFAR-wide, everybody really boosted their success with children, topping 1 million children and adolescents by the end of 2016. So I'm going to structure this on the 390s just to take us through examples and then point out which pillars were addressed by the examples that I'll give as well. I think as we knew and learned clearly through the ACT experience, finding children is even more difficult than finding adults with HIV. The prevalence is lower. Some of the strategies that are already somewhat difficult in adults are costlier and even more inefficient for children. We know that the PICT strategies are critical for finding children, especially those who are sick or symptomatic. But if we rely only on those, we miss too many children who are not yet symptomatic at a time when it's even better to catch them and put them on treatment. And so really what we learned is that the strategies we needed to focus on for children were those that found children through connections to adults and other children that we already knew had HIV. And this included optimizing our PMTCT follow-up, included family-based testing, and including using our OVC programs to find children. So in this example in Mozambique, what we saw is in many programs, if you see here at the beginning, we know that testing children who are admitted to the hospital is a critical entry stream for finding children with HIV. But as you can see at the beginning, only 24% of children who were admitted to the hospital in this example were actually getting an HIV test. So through dedicated tracking and planning and sensitizing staff over the period of several months, you can see that the coverage increased to 72%. So optimizing the important entry streams in terms of coverage in this example and in many other examples was a critical way to reach and find more children. In this example from Tanzania on index client testing, you can see that by enumerating the number of children who were either the children of or siblings of other people that we knew had HIV and were in care, that this program, through active follow-up, was able to have very high success in getting those children of index clients tested for HIV in the 80 and 90% range. And the positivity rate reaching 4 and 5% is actually a very high positivity rate when it comes to testing children. So again, reaching kids through people we already know have HIV, most cases through their parents. I'd like to show you this as just a, again, practical example, this one from Lesotho, of the kind of tracking card that was developed for use that enabled this program to really enumerate the children that a given individual had, and then track whether that child was brought in for testing.
Where are the others?
I'm getting some help on the audio here, so please mute if you are not intending to speak.
Are there others? Where's ones and others? Daniel, sorry. Where are the others?
Right, so others? You can see that as Lesotho launched this card, they were very successful in getting very high rates and positivity with testing their partners and, as you can see in particular, testing children with a 4% yield. TB we know is an important entry stream for finding children with HIV, but we also know that it's not as fully optimized as it could be. So in this example from Mozambique, by special training of cough officers, sensitizing other staff,
Hello?
and I'll draw your attention over the course of this year that the red bars, which represent the number of children with TB who had an HIV test, increased dramatically from 67% to over 90%. And then the purple bars, those children who tested positive, the linkage to ART went from 56% to 84%. So a really important and promising area in the TB arena. The other area I mentioned was optimizing our EID cascade, and we saw PEPFAR-wide even as recently as last year that only about half of HIV-exposed infants were tested by 2 months of age. We know early testing, identification, and linkage for those who are positive to treatment is key for survival. And yet even among those children identified as positive as infants, only about half were linked within a year of age. So while this example doesn't come directly from ACT, it is from Mozambique and took place at the same time as ACT was taking place, and is an example of a promising practice that we're looking at carefully. And it showed that by using point of care rather than conventional standard of care for performing EID testing, they were able to dramatically improve the proportion of infected infants who started ART by 2 and 6 months, and improve the retention at 3 months. Although you can see, even with the point of care testing, retention at 3 months of 62% tells us we still have a lot of work to do. So that was the first 90. So second 90, again, during ACT, WHO recommendations came out, signaling new recommendations to treat all infants, all children, and all adolescents with HIV. And one of the critical parts of making that work right is really getting linkage to work better. It wasn't enough to identify children and adolescents with HIV, but actually to get them onto treatment. And so in this example from Tanzania, where they observed low linkages, their intervention was to place a focal person at testing points to actually facilitate escort over to the treatment center. And they made use of their orphans and vulnerable children case managers, again, to support this linkage and even to support same-day initiation of HIV care. And I don't have the result. Oh, there, I beg your pardon. And you can see the results improved from 71% at baseline to nearly uniform linkage to treatment, a real success. So one of the other things when it comes to the second 90 is really making sure that we're using the best drugs. And so we worked hard through ACT with individual countries to facilitate the uptake of the lopinavir-ritonavir preferred regimen for young children that we know works better than nevirapine. We know that that drug in its original form tastes horrible, and so part of what we did as well was helped to uptake of pellets, which are more palatable and had a lot more advantages. But there's still much work to do and much hope that future regimens will be co-formulated and integrase inhibitor based for children. And so part of the Start Free, Stay Free, AIDS-Free agenda, and particularly the AIDS-free area, is proposing an acceleration process, a proposal that really looks at the process for optimizing pediatric drugs and getting them available and uptaken in a way that will not take many years, but just months. The third 90 really gets us to issues of retention and quality of care and virologic suppression, many barriers we know that we have to deal with there. In this example from Tanzania, looking at retention, they had observed low retention and so used children's clubs and peer counselors to help work on ways to improve the retention, and in addition, lay counselors to track clients in the community to make sure that they were coming back. And in this example, they were able to show that the retention improved from 78% to 87%. A dramatic improvement, although I would say still some additional room for improvement. In this example from Mozambique, a family care approach, which instead of considering the individual child, looked at the whole family and thought about ways to make it easier for the whole family to get their labs together, their visits together, their ARV pickups together, would be a way to really improve the retention for all involved. And in fact, they were able to show in the red line on the left for pediatrics and on the right for the adults that retention was much better for both groups with this family care approach. We know that virologic suppression has been a concern, and with viral load scale up, as an example in these three countries, you can see that virologic suppression rates were only in the 60s. And so it brings up the importance of differentiated care for children as a way to help improve not just retention, but also supporting adherence, supporting better outcomes in terms of virologic suppression. And so in these two examples, one from Mozambique and one combined from Kenya and Uganda, by looking at including children in community adherence groups in Mozambique and looking at streamlined care models in Kenya and Uganda for children, you can show that these produce outcomes that are not just process outcomes, but reduction in loss to follow-up, improvement in mortality, improvement in retention, and improvement in virologic suppression. We saw from our FIAs fantastic and exciting results about virologic suppression at the community level, but still, as you can see in the red circles, concerns for the youngest groups who were looked at here, the children, the adolescents, and the youth. And in fact, if you look at the 15 to 19-year-olds, they are the ones least likely to be aware of their status. So really concerns there across all the 90s for youth and children. And so in this example from Kenya, it's the 000. I really like this idea, which uses adolescents and youth as peer counselors to help form a peer group that works together towards 0 missed appointments, 0 missed pills, and 0 viral load. And after 12 months, they were able to show an improvement in retention from 78 to 90%, and virologic suppression that improved dramatically from 62% from closer to 90%. Just a reminder that that the ACT process and the work that we continue to do with all of our partners really directly supports the AIDS-free part of the Start Free, Stay Free, AIDS-free initiative with these incredibly important goals that we'll need to end the AIDS epidemic among children, adolescents, and young women by 2020. I really appreciate your attention, and I look forward to the other presentations and questions. Thank you.
Thank you so much, George. That was a really rich and fascinating presentation. People have been asking if the presentations will be available. This is being recorded, and I'm sure the presentations will be made available to people. So now I'd like to introduce from CIF, Dr. Alvaro Bermejo, who's the head of our Survive and Thrive team here at CIF. And he's going to speak about the role that CIF played in terms of the role of private sector in the partnership. Alvaro doesn't have slides, but we're just going to direct you towards the ACT website at the end. So thank you, Alvaro.
Thank you, Kate, and thanks to the previous speakers. I'd like to spend just a few minutes sort of to talk about why this was important for CIF and why we got into it. In a way, when you work at a private philanthropy, which has the freest capital in the world, the most difficult choice you have to make usually is what you're going to invest in. But this one, I think, was one of the easiest investment decisions that we had to make. The opportunity to partner with PEPFAR in what has been the largest public-private partnership that CIF has made was too big a chance to miss. And it made a lot of sense because CIF had been using its capacity to innovate, to pioneer, to take risks early in the response, really trying to push pediatric HIV, and we had made significant progress. Now was the time to take things to scale, to accelerate, and PEPFAR, with its rigor, with its strength, its capacity, and its sort of evidence-driven process, provided the mechanism to do that. So we jumped on that wagon while at the same time continuing to invest in other sides of the equation, say, for example, to support normative change and to allow WHO to catch up also with the progress that was happening. So the fact that PEPFAR could provide that high-quality impact data gave us also an opportunity that we don't always have, the opportunity to evaluate how sustainable the effort is and whether, at least in the 4 countries that CIF has been supportive, we can design an evaluation that extends beyond the life of ACT to track and understand what elements of the intervention are continued and supported by the health systems. So we felt that we shared a lot in the vision, and I would say then it became real in the partnership. The way in which we have worked together, as Ambassador Birks and George have mentioned, was, I think, a great model, one in which PEPFAR did what it does very well, and where it still provided space for CIF to try and add value, to bring its flexibility, to introduce new pilots like we did in Kenya, for example, to look at how HIV self-testing in private clinics and pharmacies could contribute to the effort. So as a result of this collaboration, I think Ambassador Birks was saying ACT actually help PEPFAR as a whole. I would say ACT also helps SIF as a whole, not just because of the partnership and how understanding better how to partner, but also because this focus on adolescents has meant an important shift in the way SIF sees its mission and acts on it. And it was that realization of how adolescents were struggling with HIV treatment and adherence that has made us sort of guided some of our other investments into the future. So I would just say we remain very committed to an AIDS-free generation where every teenage boy and girl have access and agency, and where the girls can avoid unwanted pregnancies and exercise their sexual and reproductive rights. And I'd encourage everybody to have a look at the ACT webpage. There are some good films there, and I particularly want to highlight the link to the Promising Practices report that we're sort of centering this webinar on. Thank you.
Thanks very much, Alvaro. That's great. And I know I can see Jessica's just put the link to the website that we're flagging up there. There's some great films there and a link to the report as well. So thank you. Now we're moving to two presentations from two of our country partners. So I'd like to welcome Dr. Maureen Kimani, who's the HIV Care and Treatment Manager at NASCOP in Kenya. Thanks, Dr. Kimani.
Good afternoon, everyone. It's afternoon here. Thank you, Kate, for this. So I'll go straight into what Kenya did, just to give a brief background. Just to give a brief background, that our HIV epidemic is currently at 1.5 million Kenyans as at the 2015 estimate. With children, our burden for children came down from about 170s to about 98,000 in the 2015 estimate, with new HIV infections among children at 6,000 and an overall incidence of about 0.35%. So just to give a brief, that following the end of our national strategic plan, we had the Kenya AIDS Strategic Framework, which started in 2014 and will be ending in 2019. And the overall vision for Kenya.
Hello? Can people hear me? No.
Yes.
Hello?
Hello?
Yes?
Hello?
Am I audible now?
Yes.
We can't hear you.
We can hear you now, yes.
Okay. So following the launch of the Kenya AIDS Strategic Framework, the country went ahead, and the main targets in the Kenya AIDS Strategic Framework under the Strategic Direction 2 was the 1990 target. So the Ministry of Health through NASCOP went ahead and developed a national plan for accelerating HIV care and treatment. And at that point, the ACT initiative had already been ongoing. So most of the ACT interventions were integrated within the national plan for accelerating HIV care and treatment. And following that, in March 2015, the country launched the national plan. And I think the main thing at that point was, since health service delivery was already devolved to the counties, to ensure that the counties actually owned the acceleration of care and treatment and also owned the 1990 targets. And therefore, the national plan for accelerating care and treatment was disseminated to the national and county stakeholders. And at that point, all the interventions that PEPFAR was doing and any other partner around accelerating care and treatment, especially for children, but also for adults, was anchored within the national plan. And following that, a national technical working group on the accelerating care and treatment was established. And 15 national technical TA teams were constituted that supported about 3 to 4 counties, because we have a total of 47 counties. And also county engagements with all the top leadership of the 47 counties were held. And also we had specific support for the 20 PEPFAR priority counties, where we had ACT focal persons who engaged with those counties. So if you can look at the slide on the baseline as at March 2015, at the point at which we were launching the national plan, the first 90 for children were at about 51% for children and 60% for adults. For the second 90, we were at 53% for children and 55% for adults. And viral suppression was still very low at that point, because the capacity for viral load was just beginning to pick up by 2015. And based on those baselines, each of the county had sessions where they had target setting at county level for the first 90, second 90, third 90, at sub-county level, and also at facility level. So each facility knew how many people they needed to identify to get to their 1990 for their specific catchment population. Each knew how many they needed to put on treatment and how many needed to do viral suppression. And for a lot of facilities, it was basically the issue of ensuring that their patients within the HIV clinics got their blood draws and their samples were sent upwards to the central testing labs, and those are clear sample referral mechanisms, which is supported by PEPFAR. So the national set their own targets, and so for 20 across the 3 years from 2016 to 2019, for identification by 2016, end of June 2016 was supposed to be 80% of PLHIVs, both children and adults, identified. For ART initiation was 70%, and viral suppression was going to be 90% for those who had been on ART. So some of the intervention and some of the things we can say were some of our best practices, some high impact interventions which actually yielded a lot of results, was one, ensuring that there was leadership and ownership of the ACT, both the ACT plan and also the ACT initiative. So the national program and the national partners supported the 47 counties to develop acceleration of care and treatment plans. And during those sessions, when the TA teams, the 15 TA teams engaged with their counties, they went up to the smallest facility in each county to ensure that each facility had its own targets across the HIV care cascade, and there were clear high-impact interventions, including family testing, including home-based testing, index client testing within the communities, ensuring that PITC became a routine within the facilities for both the outpatient departments and in the inpatient departments. And in addition to that, with support from Global Fund, the country conducted 2 national test and treat rapid response initiatives. And these were basically 90-day RRIs where counties were given specific targets which they were to meet across identification and treatment. It was also around this time when the guidelines, the WHO guidelines changed, and Kenya had adopted the new guidelines. And therefore we had more people, we had the people who are classified under pre-ART, since their CD4s were either more than 500, starting on treatment, and we saw a very rapid mop-up within a very short time. The counties were also supported to do quarterly county performance review forums, and also monthly data review forums were done at sub-county level, and there were weekly case reviews within most of the facilities to ensure that anybody who had needed treatment or whose family had not come for testing, anyone who had not received a viral load were actually getting those, in addition to identifying patients who had issues with adherence, retention issues, and specific emphasis put on those. During this time also, there was a lot of support through PEPFAR to recruit additional lay HTS providers who really supported the testing. In addition to that, at national level, we also did a national stock taking meeting where partners and the counties that they support came to a national meeting, and we looked at, these are the targets we had given you, where had they reached, what are the bottlenecks, and they could learn from the other counties some of the best practices that had been done for them to be able to improve. So just looking at the progress that has been made, so you can see that by March 2015, the total number of children living with HIV were about 179,000. Of course, after the estimates, that changed. So by October 2016, we had about 98,200 children living with HIV. The ones we had identified were 81,689. So almost getting to 82% for identification by October 2016. We had put like almost all of them for the second 90 of ART on treatment, and our viral suppression had really improved to up to 63% for children compared to when we had started the act. I'll skip the adult slide and just ask ourselves, as a country, we think we have accelerated, but that doesn't mean we have had no challenges. Some of the challenges we have seen is that we have rising infections among the youth. So thinking about reprogramming for the youth, the 15 to 24-year-olds, so that we can reprogram in terms of prevention, in terms of treatment, in linkage to treatment adherence, retention, and viral suppression. We also still have adherence and retention challenges among the children, adolescents, and the adults, as well as suboptimal viral suppression in children and adolescents. The other new challenge we have seen emerging is the fact that despite us having a very good scale up in terms of viral load testing in the country, from just within 2 years, we are doing over 1 million tests per year. I think one of the key things is that at the service provider level, there's still a lot more that needs to be done so that they can shift the thinking from CD4 to viral load and actually put in place a decision-making mechanisms where viral load results are actually looked at, and decisions, both with the patients and in the facility, are made on improving viral suppression within the facility. Then we still have some few challenges with quality of care for both adults and children. So some of the recommendations moving forward, now that the ACT initiative came to an end, also the ACT plan, the national plan, is coming to an end in the next 1 month. So I think some of the things we need to think about are HIV testing innovations, and the country has recently launched self-testing, and oral self-testing is available, especially to reach the unreached population, mainly the youth, the men. Then we launched our new guidelines in July 2016, and we are looking at ensuring that all HIV positive individuals are tested and put on treatment, and more of using technology, including mobile applications that have been shown to improve adherence and retention among PLHIVs, and also more of quality improvement intervention which need to be instituted within the facility. And as a national program, we have the Kenya HIV Quality Improvement Framework, which provide guidance to the county. So it's just a matter of technical assistance to the counties to make sure that these become routines or standards of care in their HIV clinics. Then the country, within the guidelines, launched the differentiated care and has gone ahead to provide a toolkit on differentiated care, which provide guidance for facilities that would like to do a fast-track system, or in counties where community ART distribution would be a possibility, and that is already ongoing. We have a few pilots happening in a few counties, but then the national scale-up is still in the pipeline and is ongoing. Then, of course, focusing on the youth and ensuring that combination HIV prevention interventions are actually scaled up, especially among the 15 to 24. So in addition to that, as a country, we had, as one of the best practice, a national ACT dashboard where every county could log on to it, and on a month-on-month basis, they could see whether they were progressing or not. And they had focal people who they would fall back on, and they would reprioritize interventions in areas that they were not doing so well. Thank you.
Thank you so much, Dr. Kimani. That's fantastic. And just a reminder to everyone that after the next speaker, we've got some time for questions and answers. So if you've got any questions, do please put them in the comments box, and I'll make a note of them. So now I'd like to introduce our next speaker, our last speaker for this half. And this is Dr. Chipepo Kankasa, who's a pediatrician, and she's director of the University of Zambia's University Teaching Hospital's HIV/AIDS program. Thank you very much. Welcome, Dr. Kankasa.
Good afternoon. You can hear me?
Good afternoon. We can hear you fine. Go ahead.
Okay. Thank you, Kate, and thank you to the previous speakers. In the room, I've got Dr. Woa from USAID office, and then I've got Dr. Rokaya, who's also a pediatrician and works at the Pediatric Center of Excellence. I would like to look at the epidemiology, the current epidemiology of HIV infection in Zambia. We had done a Zambia study last year. It was conducted from March to August, and this was done in order to measure the status of Zambians living with HIV, Zambia's national HIV response. This is the first study that has produced program data, because previously we used to depend on spectrum estimates. And when Zambia has given us 95,000 of children living with HIV, Spectrum 2015 gave us 89,000, while Spectrum 2014 gave us 149,000. Unfortunately, our targets were set on the Spectrum 2014. But right now, we are using the estimated prevalence of children living with HIV of 95,000. And this is what we use to plan for COP17. That's a map of Zambia. It's just showing you people living with HIV. And then on the right, it's people living with HIV, mostly adults. And then on the left, we have children under 15 years of age in Zambian district with living with HIV. Now, of interest, if you look on the eastern side, you'll see that we call it Muchinga and Eastern Province. You see that proportionally there are more children that have got HIV, living with HIV, than adults living with HIV. So I would like to go and say exactly what's happening in these provinces. There might be newly created districts, but maybe the PMTCT program is not working as well as in other districts. And that's a map of children living with HIV on treatment in Zambia. You can see mostly, this is what we call the line of rail. Most people live along the line of rail, but you can also see that even on the northern side, we've actually got a lot of children that living with HIV. We've got some white spaces there. If you look at them, some of these are newly created districts, and obviously, when this map was being done, I think they hadn't started reporting as standalone districts. So framework for success. We've got a very enabling environment. The response is led by GRZ at all levels of healthcare. We've created guidelines and SOPs to guide implementation. So everything is standardized. And the HIV treatment policy is that from 2013, we've been treating all children that are under 18, under 15 that were HIV positive. So we started start and treat in 2013 for children. Age of consent is still 16 years, except for emancipated minors. Emancipated minors meaning those children living heading households, or the married children, not mostly young wives. And then universal test and treat since December 2016. So right now, if you identify anybody living with HIV, whether adult or children, independent of CDC, CD4, and also independent of viral load, to start them on treatments. And we're also using these prescribers. We've seen a very big community engagement. We've created synergies between community-based organizations and health facilities. And this has worked out with great success, because now we are now seeing referrals from health facilities to HIV community, level services, and vice versa. Joint planning and coordination meetings are being conducted with partners and communities, so they'll tell you what they want and what the priorities are. That's where we are seeing that there's community ownership of the programs, and the programs are running better. And then there's ongoing mentorship of community health workers for home adherence and support. Tailored packages. We've got some tailored packages because we've seen that when you standardize care, then all the partners will be mentoring and training people on one standardized version of care, and this has worked out very well. So we've developed community comprehensive childhood and adolescent HIV care training packages, and it has been disseminated and it's in use. So this is community comprehensive childhood and adolescent HIV care. We've also developed a standardized comprehensive manual for adolescents, peer educators. This is for adolescents, older adolescents that are living positively. They've been trained as peer educators, and they are very active in adherence counseling to the younger one. And they also stand as good ambassadors, because most of them now are in universities and in college. So when they do adherence to the younger adolescents, the message is accepted better than when the health workers are talking to them. And we've encouraged support of support groups in all ACT facilities, and these are mostly led by community volunteers, but we've also got young adolescents also helping the community volunteers doing child counseling. So improving pediatric HIV programming and Leaky Cascade. Very importantly, we need to find where these children are, where are these HIV-infected children, adolescents. And so we've had to scale up PITC. And initially we started PITC in very high volume, big hospital, but now we are doing in all health facilities and in priority pediatric services. For example, in the TB clinic, in children admitted in hospital, in nutrition clinics, And now we are also including in under 5 clinics when they come for immunizations. The scale up of EID sample collection, transportation, and we are really encouraging to have a shortened around time so that we'll be able to find these children when the results are out. And then there's community-based tracking. Some partners are supporting community-based tracking of HIV-exposed infants through the use of SMS technology, like a program called Mwana, and using facility staff and community-based agents. There are also SMS called Remind Me that use SMS technology to remind mothers to visit the facility for postnatal care, including early infant diagnosis. We are also encouraging partners to create databases so that they can flag off, along with the laboratory, they can flag off results, and so that the children can be followed up as quickly as possible. The government 2 weeks ago initiated a campaign known as Know Your Child HIV Status campaign. We'll see how this is going to turn out. We're also working in improving linkages. To improve linkages, we've had to identify all the gaps in the cascade of pediatric HIV care and treatment, and then rapid linkage to treatment for children who tested positive, community track and tracing system for children lost to follow-up. Campaigns to follow up HIV-infected children not yet on treatment are being initiated, as I said earlier, and increase the number of pediatric KRT clinics. Some health facilities used to do maybe 1 or 2 clinics per week. We are encouraging them to do 5 clinics as possible per week, that is. And then provision of viral load testing. Initially, viral load testing was not very common, but the government went ahead and bought 10 viral load machines so that there was a viral load machine per province. We are hoping that this will be open to more viral load testing, maybe at district level, and for those far-flung places, maybe you can do point of care. Using peer support groups to enhance adherence and disclosure. So these peer support groups, mostly they are adolescents living with HIV, but we've also got mother support groups so that we bring them along just to discuss how they are coping with their children at least once in a month. We are also trying to improve the healthcare workforce, capacity building, training of healthcare workers and community volunteers in pediatric services. And what we've been doing lately is actually once you've trained them, then you conduct on-site focus mentorship. This helps them identify the gaps, and then with them together, you make sure that you sort out problems, how to overcome these gaps. We also do teleconsultations and mentorship for healthcare workers through the HIV export hotline. Here at the Pediatric Center of Excellence in Lusaka, there is a hotline, and then healthcare workers that want to make a consultation or not too sure what to do, they phone in, and we've got a telephonist who answers and is able to direct the questions to appropriate consultants. This was actively started for pediatrics and adolescents, but of late we are getting a lot of questions for adult care, for PMTCT, and then we also are able to appropriately connect them to those consultants that are seeking advice from. As I said, this is just for healthcare workers. We've had some mothers who got our number and they phoned in, and we usually direct them to say this is not their platform, but if we're able to answer what they want to do, what they want, we're able to answer that. Revision of adolescent HIV care treatment training curriculum. So we had this curriculum, but as you know that we've changed guidelines, so all these old curriculums have to be updated to make sure that everything that is contained in the new guideline is also entered there, so that you are talking one language in training manuals as well as in guidelines. Laboratory commodities. As I said earlier, viral load machines were procured for all 10 provinces. And we've got improved laboratory management system, like in big hospital of the University Teaching Hospital. We've got the LIMS, and also it conducts lab EQA. We go out to provinces to just make sure that the lab's results are as they should be. Mentorship in DBS collection and documentation. We do that once in a while, especially when we have new nurses coming on board from training. So improving pediatric HIV program and leaky cascades. As you know, in Zambia, we use the smart care. So we had to create a platform in the smart care to link index clients, linking them to contacts. So there's a platform where you enter, and then the index client is once linked, it will show that the index client has been linked to contacts. Sustaining the response. Government standards, policies, and systems will ensure continuity of practices, because as I said in my first slide, that government is actively involved. They make sure that they are involved as we make the guidelines, and of course they've given us good policies, and services are implemented within government structures and performed by government employees. Financing of the response by government, e.g. drugs for third line treatments. As everyone knows, PEPFAR supplies first line and second line, but the government of Zambia has gone ahead to buy drugs for third line treatments. We don't have a lot of people on third line, but we've seen that there are some adolescents that have had to graduate to third line because of poor adherence at that time point. So acknowledgements to the government of Zambia, and then the American people, and PEPFAR and OIS cooperating partners, and of course our patients. Thank you very much. I've got a map there for those who don't know what Zambia is. It's that little butterfly in the southern subcontinent. Thank you very much.
Thank you very much, Dr. Kangata. That's a fantastic presentation. And actually, I love your animated map of Africa with Zambia there so clearly. Thank you. So thank you very much to the speakers that we've had in this first session. I'd like to draw everyone's attention to the fact that we've got half an hour before we're due to end, and we've got 2 more speakers. So while we do have some time for Q&A, we're going to have to be quite quick. So I'm going to draw Dr. Maureen Kimani's attention to the fact that quite a few of the questions are for her. So I hope she's still with us to answer. And I would suggest that, I mean, I hope you can see the questions, so I'm not going to read them out. I'll summarize that we've got asking about interventions to identify children exposed to HIV. Some good questions, some great questions about the ACT dashboard, whether it's still being used. And I think this question about, you know, continuity and sustainability of some of these great interventions are really important. And then we have some questions which are quite technical actually about estimating the quantity of HIV tests, and then how Kenya is going to be using self-testing for children and linkage to care. And then a final question about guaranteeing privacy. So, and that's potentially from everyone, but, Dr. Kimani, could I suggest that you, aim to speak for 2 or 3 minutes to respond to these questions? I know that's not very long and you won't be able to go into much detail, but I'd like to make sure that we've got time for the other speakers and some more questions at the end. Yeah, 2 or 3 or 4 minutes, please. Thank you.
Okay, thank you, Kate. I'd like to respond to some of the questions that have been raised by the other colleagues. So the first one is around the how we're gonna identify the HIV-exposed infant, given that maybe about 60% of our mothers come to the clinic when they're pregnant, and even fewer come for delivery in health facilities. So what we have done with the unit that deals with the GAPf, the Kenya Expanded Program on Immunization, is to ensure that within the immunization registers, we have entered a new column on HIV status for all the infants who come for the first immunization at 6 weeks, and even up to the 9 months, up to the 15-month immunization visit, so that at each of those points, then the MCH or the nurse in the child welfare clinic is actually able either to test the mother, just to know whether the child, to talk to the mother and to test them and to actually document the result of that test within the immunization register. And it's usually now picked up by the PMTCT teams to ensure that that child gets onto the PMTCT program, is started on whatever intervention, the prophylaxis, the EID test at 6 weeks. And in addition to that, in some counties, we are just about piloting birth testing, so that when mothers are within the maternity, and we've seen an improvement in the delivery within healthcare settings because of the Beyond Zero campaign that has been led by the First Lady for the last 4 years. So, and also the incentive to ensure that all deliveries within the public sector are free of charge. So we've seen an increase in the number of mothers that are coming to the health facilities. And now, right now, it's around 60-something%, around 66%. So that's a great improvement. And we are hoping in the future with birth testing and ensuring that at the first visit that the child is tested, then we'll be able to identify more and more children when they're still infants. The other question was around the ACT dashboard. Previously, the ACT dashboard for those 2 years was an Excel-based dashboard, but the program, and you could only view the Cascade, the 1990 Cascade, only up to the county level. So what we've done is that with support from PEPFAR through the Health Policy Project, we are updating the dashboard to make it a web page, so that we are able to view we're able to view up to the sub-county level, and even within sub-county, the sub-county can actually see which facilities are meeting their targets and which facilities are not meeting their targets, and some of the maybe system or structural issues or even service delivery issues that are coming into play with regard to that. So the ACT dashboard will be revamped, and for anyone who would want to view, it's usually on the NASCOP webpage at nascop.or.ke. But for now, it's currently not working, but it's been revamped. The other question I saw was around the self-testing. So we've just recently launched our self-testing together with the PrEP interventions in the country. And for self-testing, our initial target is, as I said, the men and the youth, and of course, anybody else. It's been launched in the private sector as well. So it's available within the public sector, paid for by PEPFAR, and also some by Global Fund. And also it's available within the private sector, where currently the cost is about almost $10, $8 to $10 in the private sector. So anyone who wants to test themselves can actually go and get a kit and get tested from those areas. In regards to the age of testing, who can give consent according to our national guidelines, adolescents 15 years and above are able to give consent, but anyone who is younger than that will need to assent, and also parental consent or guardian consent would be required before they can actually get tested by a healthcare worker. And we are still rolling out the self-testing, so I'm sure we'll be able to see how that goes. I think one more question was around.
Sorry, Dr. Kimani, I'm going to have to move on. I'm very sorry to interrupt you, but I think we won't be able to cover all the questions, and I know we've got some more presentations to come.
Okay.
Thank you. Stay on the line. We can see some really fantastic questions coming through. But at this point, I'm going to move us on to the next speaker, who I believe is Dr. Gottfried Hörnshaw. He's the director of the HIV and AIDS department in the Global Hepatitis Program at the World Health Organization. And I'll try and make sure we have time for questions at the end if possible. But for now, I'd like to introduce Dr. Hörnshaw. Thank you.
Good afternoon, good morning, everybody. It's a real pleasure to have this opportunity to talk to you, and I want to specifically thank our colleagues from PEPFAR and CIF and also from UNICEF, of course, for organizing this event. And really, the idea, obviously, of my short presentation, and I'll be very brief in the interest of time, is to see what has been the learning from, and also how can we build on the learning from ACT that has happened so far. So I would like to just zoom out for a moment, and this is a very crowded slide, but in essence it shows you the strategic pillars of the global health sector strategy of WHO, and it really shows you the three pillars that speak to the what. In other words, what interventions for impact, the how to deliver in the best way, and obviously having equity in mind, and also how to finance. And clearly, these are three important elements that need to be also now applied for children and for adolescents. And I want to walk you through a little bit each of those elements, the what's, the how, and the financing. So for the what, as I think you're all familiar, we in WHO have tried and will continue to work and emphasize our normative role, and we have developed consolidated guidelines that speak to which implementation would produce greatest impact. And we see that really as a tool to ultimately save lives by obviously achieving impact and reaching the treatment targets that we all talk about. And what's central to these guidelines is obviously that we need to test earlier, and we need to bring the tests closer to where mother and children are. We need to treat earlier, as early as possible. Also, we need to treat better with the age-appropriate formulations, with the best medicines available at any given time, and we need to see how best to tailor the services. Again, tailoring to the specific needs of children, tailoring to the specific needs of adolescents. What we have seen, and that has been extremely encouraging, that the last generation of guidelines that includes also obviously these pediatric and adolescent relevant recommendations has happened very quickly. And actually countries have moved quicker than they have been responding to earlier generations of guidelines. And there may be various factors that contributed to that, including a great consistency across the partner organizations, many of them actually being on the phone in this session, to really propose and recommend the same WHO recommendations, that consistency across the partner organizations. But also some of the investments that WHO made and some partners made really in explaining these recommendations and in fostering a policy dialogue and an environment in which these recommendations could be taken up very quickly. What we know and what we've seen consistently is support is needed, and support will be needed also in the future, because obviously every country has to go through a process where these recommendations are being adapted, and ultimately the best ways, the smartest ways of implementing them needs to happen. And certainly that has been at the center, at the core of WHO's work in countries. In other words, taking our global normative work downstream into policies. Now, let me talk a little bit about the what. And here really you have been seeing this in previous slides, the ACT framework and the ACT programmatic pillars. But I really would like to argue that ACT has functioned as an important avenue to really find best ways of a rapid introduction for the recommendations for children and adolescents. It's been really a key channel in the various pillars, from community engagement down to strategic information, and has been really a critical opportunity to test the how-to of many of the new recommendations in obviously very different contexts. And that very impressive report, the Promising Practices report, obviously documents that, and I hope that many people will be able to see that, read that, learn from it, and that we'll have many fora to hear even more about that. If we now look into the future, obviously there is the opportunity, and certainly the responsibility for us in WHO to see from what we have learned how will that influence future guidance that we provide to countries. Both from certainly from an implementation perspective, we have learned lessons in all those pillars, starting from best ways of targeted testing strategies, looking at community interventions at various steps of the cascade, obviously, looking at the services again, how they would best be tailored to adolescents and their specific needs, on how best to track and improve performance using communication technology, and really also in terms of providing supervision and mentorship of the various types of healthcare providers, including obviously lay providers. Last, obviously, the pillar on monitoring and evaluation, to really make this part of the culture or the routine on how to collect and interrogate and question, obviously, how to improve quality on the way forward. So we see really now, as we move again into the next generation of the guidelines, a great opportunity to build on these lessons that have been learned, and actually to close the cycle at this point. Now, if we sort of looked at also the super fast track targets that we've all agreed upon, ACT really has taken us from the foundation of looking at sort of the evidence-based guidance that we've had, the implementation experiences that we've had, to the fast-track targets. And clearly, that's not the end of the story. We now need to leverage, expand, and build on the ACT successes to implement with obviously even greater focus and even possibly more targeted action. And that obviously takes us from, again, the normative framework to the acceleration experiences and how it's been documented, to the next phase, the start-free, stay-free, AIDS-free movement. And in a way, obviously, we are now moving on from what has happened in ACT and more broadly in the area of beat scale up, to really say, what does this mean in the broader context of the 3 Frees initiative, and specifically what does it mean for the AIDS-free work stream in the context of that initiative. One thing that's very clear is we need to stay focused, and we must not leave the eye off the ball, so to speak. We need to keep attention to it, because obviously the job's not done. We need to take what works and what we want to scale in all the AIDS-free countries, the priority countries, so to speak, and we still need to also do some work at the global levels. We have to unlock some of the barriers that exist, or some areas where we need further optimization is needed, and one of those is obviously to get the medicines in the appropriate formulations and the appropriate medicines for children out there. And many of you are familiar of the work that WHO does with a range of partners on the global accelerator for pediatric drugs and formulations. There's obviously also some more work on the diagnostics, point of care diagnostic that needs to happen, and other areas. We will have to continue to adapt. Again, it's not, lessons learned are important, but it's not necessarily a one-size-fits-all. We will have to adapt to different contexts and also changing epidemics. And again, we'll have to support sustained action, and we'll have to use the resources that we have. We have to advocate for more resources, but we'll also have to optimally use the resources that we have. If indeed we want to reach fast-track targets, 1.6 million children on AT 2018 and 1.2 million adolescents. This is basically to acknowledge, again, ACT has been summarize, has been an incredibly important initiative. It's been a very focused initiative. It's one that has been done with many partners, and certainly is a foundation on the way forward. And we as WHO continue to be committed. We are one of the co-chairs of the AIDS-free work stream together with GAPf, as you know, and several of us are on the working group. And we certainly see, as I've said, the need for staying focused and very dynamic in this area. Thank you.
Thank you. Thanks so much, Dr. Henshaw. That's fantastic and really great to hear the perspective from WHO. And as you say, passing the torch over. So now I'm aware we've got 10 minutes before the end of the session, and we've got a lot of great questions coming in. So I would encourage those of you who can to answer the questions using the comments. And but for the time being, I'd like to welcome Dr. Stephen Lee, who's the Vice President for Program Implementation and Country Management from the Elizabeth Glazier Pediatric AIDS Foundation. And Dr. Lee is going to be speaking about the progress and link to AIDS-free. Thanks, Stephen.
Thanks, Kate, and good morning and good afternoon, everyone. I also would like to thank the organizers, PEPFAR, SIF, and Jessica with UNICEF for inviting me and supporting this webinar. Okay. Computer's not working. So moving on to the next slide, as just a reminder that the global and fast track, the Start Free, Stay Free, AIDS Free is a global and fast track approach to the scale up of prevention, treatment, care, and support for children, adolescents, and young women. And this is a coalition led by UNAIDS and PEPFAR. And as George mentioned, and I think Dr. Henshaw also mentioned, the ACT initiative really contributed significantly to the AIDS-free component of Start Free, AIDS-free. And for us to really achieve the 95% of children enrolled in ERT, we really have to focus on many of the opportunities and many of the lessons learned and promising practices that's been articulated in the report. Next slide. So Dr. Burks also really outlined this as well in her presentation, the success of ACT in terms of the 561, almost 562,000 children that have been enrolled in ART through the ACT initiative, and additionally just the success of PEPFAR in general through the lessons learned in ACT in scaling up the lessons learned in ACT in other PEPFAR countries. We now have 1.1 million children with HIV who are enrolled on ART. So in terms of the ACT initiative itself, and for us to be able to achieve and generate a sustainable change in enrolling children, this is a busy slide, and what I would really want to focus on is that there are opportunities both at the global level and at the country level for us to generate and sustain this change, a lot of which we've talked about during the course of this webinar, the policy changes, the technical programmatic aspects and interventions that have been successful, really the community engagement. Many of the examples both in the report, but then also the examples that have been shared by our colleagues in Kenya and Zambia really reinforce the need for community engagement and linking and working with communities to move the agenda forward. And another area I'd want to articulate is really around the use of data and the real importance of the M&E components for us to really understand where we are in the epidemic, what is working, what's not working, where is it working in terms of various populations and in various age groups. Next slide. So I really found the report very useful and very informative, and I've actually copied this or transformed this from this slide from one of the slide figures in the report, and it's really looking at the treatment cascade. And I think one of our speakers talked about the leaky components within the treatment cascade, and this really outlines for us, based on the various ACT pillars, interventions targeting the cascade: identification, linkage, treatment, retention, and monitoring of care and treatment for children. And it really provides us a great opportunity for targeted action to ensure that the treatment cascade for children is successful. Next slide. And finally, this is also a figure from the report, and this is I think Dr. Hernshaw also just included this in his presentation, but it really maps out a roadmap for what works for accelerating children's HIV treatment. Again, many of the speakers, but especially our country colleagues, outlined the various components of this figure, and outlined interventions that have been successful in addressing these various pieces. So I'm going to stop here in the interest of time. I realize we only have 5 more minutes before we have to end, and really just want to take the opportunity to thank our colleagues at the Ministries of Health in the various countries, the 9 countries that participated in ACT, the implementing partners who contributed to the report, but then also the implementing partners who have contributed to sharing their lessons learned and in implementation, and obviously our colleagues at PEPFAR, SIF, and other UN agencies who made the ACT initiative possible. Thank you.
Thank you so much, Dr. Lee. And thanks for your timeliness too. And I think one of the things that's really exciting is seeing the link from ACT into the AIDS-free initiative, and thank you for making that link. So we have 5 minutes, and we can't answer all the questions. I do encourage people to answer in the comments. But there's some questions about how we can help community agents do the tracking of children lost to follow-up, but also questions about how we manage confidentiality amongst community agents. And I wondered if anybody would like to answer those questions, particularly this question about those 2 questions: confidentiality and linkage to care, including linkage to care from HIV self-testing as well, which would be interesting. Would anybody like to do that? Maybe on the, Dr. Kimani, on the point of Kenya and the HIV self-testing and linkage to care.
Thank you, Kate. Around the HIV self-testing, the kits that we have in country and the ones that are planned for procurement have a hotline number, which is at the national level, at the National AIDS and STI Control Program here in Nairobi. We have a patient support center and a clinician support center, and we have clinicians and counselors stationed there who would receive the calls and have a directory. We have also developed a directory of services which can easily be accessed by anybody who has tested positive and they're not sure where they should go for a confirmatory test after their oral testing becomes positive. And also have a hotline which we have nicknamed Ushauri, where they're able to just call in and just find out about within their locality, whichever county they are, where they're able to access the services, whether it's a government facility or even within the private sector. So for now, as I said, we just launched in May early this month. So we are hoping that some of these things are things that you're going to learn from. But for now, someone asked about how we quantified for the test kits that we have procured. And as I said, it's just we just took a small proportion of within the year 1 of our implementation of the male population, and then the youth population, as well as our key population, that is the female sex workers, the MSMs, and people who inject drugs. so that they're able to access the services. So just a proportion, 30% within year one, will be able to access the oral test kit, and that is what we have worked with. But as I've said, the test kit is also available within the private sector, and anyone who is able to buy it can actually buy it. Thank you.
Thanks very much. I'm so sorry I'm not able to give anybody else a chance to answer any questions, but I've noticed that Dr. Kankasa has given us good answers about the, I was going to ask her to speak to the points about community health workers and confidentiality, and she's made a response to that, so thank you very much, Dr. Kankasa. So it's time to wrap up. We're just approaching the top of the hour. And I'm so pleased to see the number of people that have participated with fantastic questions and engagement. I noted 156 participants at our greatest number, and many people were joining in groups. So I'd like to thank you all for joining, and thank you all to the large numbers of people that have been involved in all the work of ACT and in the report. And I'm glad to see the author of the report, Sarah Middleton-Lee, giving us references to places where you can find the answers to some of the questions you've been asking. And so that's it from me as your host, and I'll hand back to Jessica as the moderator and say goodbye and thank you very much.
Thank you again, everyone, for joining us and taking the time out of your busy schedules. Thank you to Kate Harrison of SIF for moderating, and to all of the presenters who joined us, from Ambassador Burks to Dr. George Syberry, to Dr. Alvaro Bermejo, Dr. Stephen Lee, Dr. Gottfried Hernschall, Dr. Kankasa, and Dr. Kimani from Kenya and Zambia. I think they were very engaging presentations and questions, and we'll be making the presentations and recording available so that you can use for reference or share with your colleagues who were unable to attend. So we look forward to joining you for another webinar, hopefully sometime next month in June, and wish you all a wonderful day. Thank you.
Wonderful. Thank you.
What is it?